It's a great time in oncology because of the tremendous advances that have been made in immunotherapy for cancer, something that a lot of people have waited a long time for. So we had ipilimumab, and now we've got a couple of PD-1, PD-L1 drugs that have been approved by the FDA. To this point, the clinical implementation prescribing behavior has largely reflected around the indications as defined by the registration trials, and to a lesser extent, NCCN's influence on interpreting where these treatment options belong in the therapeutic armamentarium of, at this point, melanoma, non-small cell carcinoma lung. The payers have generally managed to the labeled indication and the NCCN guideline. The NCCN recommendations at this point for those three drugs are all 2A or better. So it's been pretty straightforward. What's going to happen in the future is a little less clear to me. It is pretty clear that the drugs are quite effective in some diseases and not quite so effective in others. And of course, we lack a biomarker, so it makes it really, really difficult to try to identify that enriched group of patients who are likely to benefit from therapy. But at this point, I think essentially every payer has taken the tack that these are really therapeutic advances, and access should not be a problem.
So I recently had the pleasure of writing an article for Evidence-Based Oncology that addressed the questions of stakeholder adoption for immuno-oncology. So I've just completed a lot of research in the subject, so I feel pretty confident. The limitations right now are by diagnosis, FDA approval. All immuno-oncology was really in the world of melanoma treatment. We now have the first drug approval in lung, relapse lung cancer. And so this is an area that looks like a class of drug that will be broadly applicable to malignancy. And so the number of potential cancers could run up to 20 or 30 as the clinical trials conclude, and if the benefit is across all disease areas.
The usefulness of biomarkers in selecting patients for treatment with any of the immunotherapeutic drugs at this point, in my view, is not very good. So I actually just recently participated in an FDA ASCO AACR symposium that discussed this very issue. I would say that the one biomarker that is being most promoted is PD-L1 expression based on immunohistochemical staining. But if you actually look at the data, and there's a number of studies that have now been published, it is true that expression does correlate with a modest increase in likelihood of response. However, it's equally clear that patients' specimens that do not stain for the biomarker by no means are excluded from the likelihood of clinical benefit. So if you just think a second about what's the benefit of having a biomarker. And I think the benefit from a physician's perspective is it tells me somebody who's going to benefit or not going to benefit. And the truth is, it's the same for the health plan as they write coverage policy. If you have a biomarker that not only doesn't enrich your population adequately for response, or more importantly, exclude patients that are not going to respond, the biomarker isn't worth a heck of a lot. And that is where we are right now in this space.
So how drugs are going to be sequenced and how the immuno-oncology drugs in particular will work their way into that sequencing is going to evolve over time. I think that for most payers, they're going to restrict utilization based upon label. So you'll see drugs that, based on the initial clinical trials, which were in relapse patients, will be used only in those relapse patients. The excitement over this class of drug, the excitement on both the provider level and the patient level is going to become a big driver for moving these drugs up into earlier lines of therapy. And it's unclear to me because the clinical trial data set at this point is too limited to know if we're going to see it in combination with traditional drugs or we're going to see them being used independently as single agents, or see them used in combination, but in combination with other immuno-oncology agents. Like everything we've seen in cancer, when you do combine agents, you typically add toxicity. And part of the beauty of the PD-1 class of drugs over the prior immuno-oncologic agents is a fairly low toxicity with a fairly high efficacy. And that's a unique thing. That's kind of the holy grail that we look for in oncology, drugs that are very effective and not terribly toxic.
Sequencing of immunotherapeutic agents at this point is not such a big issue because there just aren't that many of them. The one example where there is a sequencing question is the ipilimumab PD-1, PD-L1 sequence in malignant melanoma, where NCCN has come out and made a statement that they believe that PD-1, PD-L1 should be considered as first-line therapy in patients with locally advanced or metastatic disease, if you will, somewhat leapfrogging the published evidence base. And they made that recommendation based on what they felt was less toxicity associated with those agents compared with ipilimumab. Obviously, we would like information regarding the optimal sequence, but the fact of the matter is that we may never get that information, and so I don't think it's an unreasonable thing to say. I think it's going to get more complicated as we get more novel immunotherapies, especially when they have a different mechanism of action. And at what point it makes the most sense to use one agent versus another. And I think we may actually need some sort of change in the way we collect that evidence to help inform optimal patient care, let alone coverage policy.